Hi there, I'm Brian Thurber. I'm a neuroradiologist with an interest in educational videos. In this video, we'll discuss the cervical spine and soft tissues of the neck. Let's start by taking a look at this normal lateral neck radiograph in a pediatric patient. We can assess the alignment of the cervical spine by following the slightly lordotic curvature of four important lines. First, here's the anterior vertebral line. This will run along the anterior surfaces of the cervical vertebral bodies. Second, here's the posterior vertebral line, which will run along the posterior surfaces of the cervical vertebral bodies. Third, the spinal laminar line. The spinal laminar line runs here along the posterior margin of the spinal canal, along the anterior aspects of the posterior arches. The density that we see right here and along each cervical segment is from the point where the laminae are converging at the spinous process. This increased density here gives us the landmark to connect the different points along the spinal laminar line. Fourth, we have the posterior spinous line, also known as the spinous process line. This will follow along the tips of the spinous processes of the cervical vertebral bodies and also follow a slightly lordotic curvature as it comes down toward the thoracic spine. If we suspect anterior subluxation of C2 on C3, then another line becomes useful to draw. This is the Swiss-Chuck line or posterior spinal line, which is drawn from the anterior aspect of the posterior arch of C1 to the anterior aspect of the posterior arch of C3 right here. This is the posterior spinal or Swiss-Chuck line. This is allowed to be up to 2 millimeters anterior to the anterior aspect of the C2 posterior arch in children. This is allowable in children because their facet joints are more horizontally oriented and because they have greater joint laxity in general. The false impression of anterior subluxation of C2 on C3 may be simply from head positioning in a child in which the neck is too flexed. However, if you do have greater than 2 millimeters between the posterior spinal line or Swiss-Chuck line and the anterior aspect of the C2 posterior arch, you should suspect there is a problem, such as a hangman's fracture. With a hangman's fracture, you can get real anterior subluxation of C2. Hangman's fractures, as well as other fracture types in the cervical spine, are also associated with thickening of the prevertebral soft tissues. There are specified limits for how thick this soft tissue is allowed to be. At radiography, generally at C2 to C4, it should not be more than 5 to 7 millimeters in thickness. Some people use the AP dimension of the cervical vertebral bodies as a reference marker. At the C2 to C4 level, it should not be thicker than half of the AP dimension of the cervical vertebral bodies. Down a little lower at the C5, 6, 7 levels, it is allowed to be thicker because at this point you transition to where the esophagus is also anterior to the cervical spine. In children, it is allowed to be up to 14 millimeters down here, and in adults, it's allowed to be up to 22 millimeters. At the lower cervical spinal levels, the prevertebral soft tissue thickness should not exceed the full AP diameter of the cervical vertebral bodies. Let's now go more anteriorly and talk about the airways and the laryngeal cartilages. The nasal cavity, seen up here, opens posteriorly into the nasopharynx. The oral cavity opens posteriorly into the oropharynx. The roof of the soft palate, seen along here, will separate the nasopharynx from the oropharynx. The soft palate itself, as well as the base of the tongue, are considered oropharyngeal structures. The oropharynx will go down to the point of the hyoid bone or bases of the vallecula, where the glossoepiglottic and pharyngoepiglottic folds will separate it from the hypopharynx below. Anterior to this point, and going anteriorly and inferiorly from the aryepiglottic folds, we have the larynx. Here we have the false vocal cords, and then we have the vestibule, or laryngeal ventricle, right here, and then below that point we have the true vocal cords right here, which will go down into the tracheal air column, seen right here. One common entity we can diagnose on our lateral neck radiograph is epiglottitis. Here with our normal epiglottis, we see nice crisp margins, and we can see the aryepiglottic folds coming down posteriorly and inferiorly with slight posterior concavity going down to their bases. With epiglottitis, we get abnormal thickening and opacification of the epiglottis, forming the thumb sign. Also, the aryepiglottic folds, instead of going down with this slight posterior concavity, go more straight or can even be convex posteriorly. Also, you can get pharyngeal overdistension. This is why it is better to get expiratory radiographs in order to assess for epiglottitis, because with inspiration there may be a false positive of pharyngeal distension which is unrelated to laryngeal edema. If we get our expiratory views, then we can be sure that the distension is due to something pathologic. Another entity to know about is omega epiglottis. This is a benign finding, which is simply due to positioning of the patient or due to increased concavity anteriorly as the epiglottis goes up. This may make you look like you have the thumb sign, but the distinctness of the laryngeal cartilages should be maintained, And if it's just an issue of patient positioning, it can be corrected by just making sure you have a true straight lateral radiograph. Let's now look at an AP radiograph to discuss another issue sometimes seen in the pediatric neck. On our AP view, we have our pharynx narrowing right here at the level of the true vocal cords. Below this point, you'll notice the lateral convexities here and here of the subglottic airway as it continues into the tracheal air column. The lateral convexities, or shouldering, we see at this point is lost in cases of subglottic edema, as may be seen in cases of croup. The reason this area is particularly susceptible to narrowing is because of the loose mucosal attachments here of the cricothyroid membrane, or conus elasticus. Let's now look at an example of a patient who has croup. Here is a child who carries the clinical diagnosis of croup. You'll notice we have lost the lateral convex margins normally seen in the subglottic airway, and instead we have this inverted V configuration known as the steeple sign, indicating narrowing of the subglottic airway. Here in another patient with acute airway obstruction, we see marked thickening and increased opacification of the epiglottis, and poor definition of the epiglottis and aryepiglottic folds with the pharyngeal air. These are characteristic features of acute epiglottitis. Contrast this to a case of omega epiglottis. This lateral neck radiograph shows an example of an omega epiglottis. Here's our epiglottis, and you'll notice as it ascends, it has a concave anterior curvature, but it is not increased in opacification, and its borders remain well defined, as do the borders of the aryepiglottic folds, as seen here. Let's now move on to CT to review the anatomy of the airway and the larynx in greater detail. Here we have a sagittal CT of the neck showing the nasal cavity anteriorly and the nasopharynx posteriorly. These spaces will communicate via the choanae, which are openings on either side of the nasal septum. If I scroll toward midline here, we'll see our nasal septum come into view, which has an anterior cartilaginous component and a posterior bony component formed by the perpendicular plate of the ethmoid bone and by the vomer here. The anterior boundary of our nasopharynx will be formed by this posterior margin of our nasal septum, as well as by the choanae on either side, and by the junction here formed by the hard palate and soft palate. The inferior boundary of our nasopharynx will be formed by the roof of the soft palate along here. The superior margin of our nasopharynx will be formed by the basa sphenoid bone, which surrounds the sphenoid sinus, and by the basa occiput bone here lying posterior to the spheno-occipital synchondrosis. The nasopharynx will be bounded posteriorly by the C1 arch, as well as by portions of C2. Here on an axial CT, we get a good view of the lateral walls of our nasopharynx. The lateral walls are formed by the eustachian tube orifices lying just anterior to the tubal tonsils, by the salpingopharyngeal folds here, and by the lateral pharyngeal recesses, also known as the fossae of Rosenmuller. On this image, we also see our nasal septum, the posterior and inferior portion of which is formed by the vomer bone. We see our inferior nasal turbinates, our maxillary sinuses, and the pterygoid plates. The choanae are the openings on either side of the nasal septum seen here and here. When the distance from the vomer bone to the medial pterygoid plate here measures less than 3.4 millimeters, it is suggestive of choanal atresia. It is also suggestive of choanal atresia when the vomer bone measures greater than 2.3 millimeters in size, or when there is medial deviation of the posterior aspect of the maxillary bone in this direction. Approximately 90% of cases of choanal atresia are bony, the other 10% are membranous. You may also get an air fluid level, not unlike the air fluid level this patient happens to have in their left maxillary sinus, at the level of the choana in cases of choanal atresia. Let's next go up to our piriform aperture and talk about piriform aperture stenosis. The piriform aperture right here can also be narrowed in cases of congenital nasal piriform aperture stenosis. In these cases, there is medial deviation of the anterior portion of the maxillary bones and sometimes the nasal processes as well. You can get a triangle-shaped palate in cases of congenital nasal piriform aperture stenosis, and these cases are associated with a solitary median maxillary central incisor. Congenital nasal piriform aperture stenosis is also associated with holoprosencephaly. Looking back posteriorly now, let's talk about the tonsils in greater detail. I mentioned before the tubal tonsil, which will be down just anterior to the salpingopharyngeal folds, or posterior to the eustachian tube orifices right along here. Also on the roof of the nasopharynx, you have the adenoid tonsils. These will be located up here and tend to increase in size until about age 6 and involute by 8 to 10 years of age and almost always by 16 years of age. They can sometimes, however, obstruct the nasal airway, as we'll see in a moment in a radiograph of a 6-year-old boy. The other tonsils to know about are the palatine tonsils, located more inferiorly, right here on either side of the uvula, and the lingual tonsils, which are located in the posterior aspect of the tongue. Let me now show you a lateral radiograph of a 6-year-old boy to show you an example of narrowing due to adenoid tonsil hypertrophy. Here we have a child with marked enlargement of the adenoids. The adenoids are seen here, projecting down anteriorly and inferiorly from the roof of the nasopharynx. Here we can see them causing marked narrowing of the nasopharyngeal airway. When this nasopharyngeal airway becomes less than half of the width of the soft palate, it is significant for obstruction. Let's now go on to discuss the oropharynx utilizing our CT images. The oropharynx is seen here. It is bounded anteriorly by a line drawn vertically down from the junction of the hard palate and soft palate, like so, intersecting the circumvallate papillae on the backside of the tongue and the anterior tonsillar pillars. It contains the base of the tongue, the soft palate, as well as the palatine tonsils, seen here and here. The superior boundary will be formed by the roof of the soft palate, separating it from the nasopharynx above. Inferiorly, it is bounded by the median and lateral glossoepiglottic folds, which I'd like to show you on an axial CT. Here on our axial CT, we see the median glossoepiglottic fold right here. It extends from the base of the tongue to the anterior surface of the epiglottis. On either side of the median glossoepiglottic fold, we have the valleculae, here and here, which form a part of the oropharynx. Extending laterally, off the lateral surface of the epiglottis here, and if I scroll a little further down, here on the left, we have the lateral glossoepiglottic folds, which insert onto the base of the tongue as well as the lateral pharyngeal walls here and here. Going down a little further, I'd like to point out the area epiglottic folds, which are seen coming here, and which go all the way down to the level of the arytenoid cartilages below, seen down here. This is the cricoarytenoid joint, where the cricoid and arytenoid cartilages will articulate. Scrolling back up now, I'd like to point out some important ligaments just beneath the median glossoepiglottic fold. So here we are, looking at our median glossoepiglottic fold again. Just below this point, we're going to see this connection between the superior surface of the body of the hyoid and the epiglottis. Right here, this is the hyoepiglottic ligament. Just below this point, we have the preepiglottic fat, which is normal in this patient. It can become inflamed and effaced in cases of supraglottitis. Scrolling down more inferiorly, we see the thyroid cartilage come into view, and we'll see the thyroid notch anteriorly dip down just a little right here. And coming just below this point on the thyroid notch, we have the thyroepiglottic ligament extending from the thyroid cartilage right here and extending posteriorly and up to go to the petiole or base of the epiglottis above. Here again on our sagittal CT, we can see the petiole or base of the epiglottis right here, to which the thyroepiglottic ligament will attach. The hyoepiglottic ligament attaches a little higher on the surface of the epiglottis and runs again from the upper surface of the hyoid bone to the anterior epiglottis right here. The median and lateral glossoepiglottic folds separate the oropharynx from the larynx and hypopharynx below. The larynx and hypopharynx are in turn separated by the aryepiglottic folds, which extend downward from the sides of the epiglottis, and each comes down to the apex of the arytenoid cartilage below. The boundaries of the hypopharynx include, posteriorly, the mucosal surface here covering the middle and inferior constrictor muscle, anteriorly the postcricoid mucosa and posterior cricoarytenoid muscle, and inferiorly the esophageal verge marked by the position of the cricopharyngeus muscle. This is also at the inferior border of the cricoid cartilage or the C6 vertebra. The inferior constrictor muscle contains a thyropharyngeus and a cricopharyngeus component. Between these two components, you have a weakness known as the Killian dehiscence, through which you can get a Zenker diverticulum. Let me show you this on a swallow study. Here we have a video swallow study in a patient that was found to have a Zenker diverticulum. We start here with the barium bolus in the oral cavity. It is held anteriorly by the soft palate pressed against the base of the tongue. As we go forward in time, we'll see elevation of the soft palate, like so, going up against the palatopharyngeal ridge or possivance ridge. This ridge of tissue is a prominence of mucous tissue formed by the contraction of the superior constrictor muscle. As we continue forward in time, we'll see the hyoid bone and larynx elevate. Here they are, elevating, and we see the barium bolus coming down toward the valleculae, and then continue on and go down. Here we have our piriform sinuses, and it's going to continue to this point in the hypopharynx where we see the cricopharyngeus muscle right here. Now, a zenker is a dehiscence right here between the thyropharyngeus and cricopharyngeus components of the inferior constrictor muscle. So we're looking for contrast that will be going over the cricopharyngeus posteriorly. So as we continue forward in time, we'll see exactly that, as this contrast continues down and continues in a narrow neck down anterior to the lower vertebral bodies. We see the persistence of this contrast right here with time, and this little collection is right here. So we'll repeat this process and have the patient swallow again. So they'll get an additional bolus of barium right here, which will now continue inferiorly. And again, go right here over the cricopharyngeus muscle and get stuck at this point and go down the narrow neck right here in this zenker diverticulum. Now, a zenker diverticulum can be quite large, and it tends to be larger than the smaller Killian-Jamieson diverticulum, which usually tend to stay less than 1.5 centimeters in size. These Killian-Jamieson diverticula are going to be inferior to the cricopharyngeus muscle. We've now returned to our axial CT images, and we'll now use this image set to discuss the hypopharynx subsites. The hypopharynx subsites are the piriform sinuses, the posterior wall, and the postcricoid region. First, the piriform sinuses. These are shaped like inverted pyramids with their bases up here at this level of the lateral glossoepiglottic folds. These are also known as the pharyngoepiglottic folds. As we scroll inferiorly, we'll notice its lateral boundary is going to be composed of the lateral pharyngeal wall, the thyrohyoid membrane, and the thyroid cartilage is down here. Anterior and medial to it, we have the aryepiglottic folds. Here's our right aryepiglottic fold, and here's our left aryepiglottic fold. And more inferiorly, we'll see the apices of our pyramids. The apices of our pyramids are all the way down here at the level of our true vocal cords. We know we're at the level of the true vocal cords because we see our cricoarytenoid joints right here. Food is pushed laterally into these piriform sinuses during swallowing by the epiglottis and by these aryepiglottic folds that we see. Also, you should know that 2/3 of cases of squamous cell carcinoma of the hypopharynx occur within the piriform sinuses. Let's move on to our next subsite, which will be the posterior wall. This will begin at the level of our hyoid bone. So our hyoid bone, which is seen right here, will mark the beginning of the posterior wall subsite. It will extend posteriorly from this point all the way down to the level of the inferior margin of our cricoid cartilage. So here's our cricoid cartilage. So when we get to the bottom of this, right here, we're at the level of the bottom of our posterior wall. The next subsite of the hypopharynx will be the postcricoid region. So I'm going to scroll up to the level of our cricoarytenoid joints, which we saw just a moment ago. Here are the cricoarytenoid joints. So the postcricoid region will begin here, as you might expect, behind the cricoid bone, and it will extend to the level of the inferior margin of the hyoid bone, much like the posterior wall also ended right here. After our posterior wall and our postcricoid region end at the level of the inferior margin of the hyoid bone, we're then in our esophagus. So this is our esophagus, which we can follow down a little further. Right here is the esophagus. We'll now return superiorly to discuss the larynx. The larynx is divided into the supraglottis, which extends from the lingual surface of the epiglottis, way up here, down to the level of the upper surface of the true cords. The true vocal cords are going to be marked by the location of the cricoarytenoid joints right here. And then next is the glottis, which goes from the upper surface of the true vocal cords down 1 centimeter to the point right here where you can no longer see soft tissue in front of the cricoid cartilage. At this point, we're in the subglottis, and this will extend down to the level of the inferior margin of the cricoid cartilage, right here. The supraglottis has several structures, including the preepiglottic fat, which we previously discussed, as well as the paraglottic fat, the false vocal cords, which are going to be located at the level of the tips of the arytenoid cartilages here and here. This is where the paraglottic fat is also seen. But it is below this level where there is no fat, and the thyroarytenoid muscles, as well as the vocal processes of the arytenoid cartilages, are effacing it, that we have our true cords. Below this, we're in our glottis. Sometimes people mark 1 centimeter below the lateral margin of the laryngeal ventricles as the inferior extent of the glottis, but this can be difficult to see, especially in patients like this when there is no air between the false cords and the true cords, which is where air in the laryngeal ventricles would be located. So I like to use instead just the 1 centimeter below the true cords point, or to look for this point down here where the subglottis begins, which is where you no longer appreciate soft tissue internal to the ring of the cricoid cartilage. You'll notice I'm again using the same landmark that we used in the hypopharynx. The posterior wall and the postcricoid region also ended at the inferior margin of the cricoid cartilage. Likewise, the subglottis will end at the inferior margin of the cricoid cartilage, and at this point and below, we are now going to be at the trachea. Here on our axial T2 weighted MRI with fat suppression, we again see the trachea lying anterior to the esophagus. As I scroll superiorly here, I'll point out the cricoid cartilage. Further up, the thyroid cartilages here, and further up, the aryepiglottic folds here and here lying anteromedial to the piriform sinuses. Further up, we see the epiglottis here and the valleculae just anterior to it. This is our median glossoepiglottic fold. From here, we go up to the oral cavity. MRI of the cervical spine is often obtained to look at the spinal cord or to evaluate ligamentous anatomy, as injuries to these structures may be occult on CT. However, as we have seen, many of the anterior soft tissues of the neck may also be visible and should similarly be evaluated, even if the purpose of the study was primarily designed to look at the cervical spine. Let's now scroll superiorly up to the level of the cervicomedullary junction. This will be right here, and as we scroll down, I'd like to point out the important ligamentous anatomy, starting right here at the level of the dens or odontoid process. This ligament right here is the hypointense structure extending from the medial margin of the lateral mass of C1 on this side to the medial margin of the lateral mass of C1 on the other side. This is the transverse ligament, which is a component of the cruciate ligament. The other component will be the longitudinal fibers going up to the anterior aspect of the foramen magnum and down inferiorly. Also on this slice, we're seeing the alar ligaments. The alar ligaments extend from the lateral aspects of the dens on either side, here, and will go up superiorly to the occipital condyles. Let's now look at a sagittal MRI to view these structures in greater detail. Let's talk about the ligaments going from anterior to posterior. The anterior atlanto-occipital membrane is here and will extend from the anterior superior aspect of the arch of C1 and go up to the anterior inferior aspect of the foramen magnum. It is a continuation of the anterior longitudinal ligament below. Next, we have the apical ligament. This will go from the apex or tip of the dens to the anterior aspect of the foramen magnum, and its fibers may blend with those of the anterior atlanto-occipital membrane. Next, we have a portion of the cruciate ligament with its longitudinal fibers right here, situated between the apical ligament and the tectorial membrane behind it. The tectorial membrane is essentially a continuation of the posterior longitudinal ligament and will extend from C2 up to the foramen magnum and basilar groove of the occipital bone here. Intracranially, it becomes contiguous with the dura mater. Next, we have the posterior atlanto-occipital membrane. This will extend from the posterior arch of C1, right here, to the posterior margin of the foramen magnum, also known as the opistheon. It has two holes in it, which are necessary to give passage to the vertebral arteries. So if I scroll off midline here, we'll see that our posterior atlanto-occipital membrane right here has to give passage to this extradural segment of the vertebral artery. Once it does go through, it becomes the intracranial or intradural component right here.